Welcome everyone to the second season of Fresh Air with our awesome team of pulmonary pathologists. So we have on my left here Raghav, and we have Irene Sansano on my right, and Sanjay Mukhopadhyay down at the bottom there. And so today we're going to do something really cool. It's back to school time, and so we're going to go back to basics of pulmonary pathology. Irene has some awesome cases for us to go through, so to review some of the basics of pulmonary pathology. So take it away.
Hi, this is our first case. Is a male, 60 years old, that has a mass in upper left lobe. This is a percutaneous biopsy. It's a biopsy that they take in radiology. As you see, it's needle shaped. We see here lung parenchyma, this thing that looks like fibroblastosis, and it's normal in upper lobe. And we see also this thing here. It's a tumor. What do you think about this tumor?
For me, this is squamous just on the H&E alone, unless there's some surprise somewhere else.
Why do you think it's squamous? Because
so
of.
Can we go a little high on the
Yeah.
So here on the right side, you see these sort of nests, but here on the portion that you're focusing on, I think is just a focus of keratinization.
Okay.
You know, with these very pink cells.
Okay.
Cells with abundant cytoplasm. I really like the morphologic finding of cells that have relatively little cytoplasm, like there are on the right, and then the cytoplasm keeps increasing as you go towards the left. I think that's a very good sort of marker
do you
of
think
squamous differentiation.
A corneous pearl is forming here?
Yeah.
I tell residents not to look these pink cells too much, because necrotic cells can be this keratotic. So I pay attention to. You can see my arrow. Do you
Yeah,
see?
we can.
Yep.
Yes. So I pay attention also to these intercellular bridges. I know Sanjay doesn't like much the intercellular bridges. I say that these are more reliable than the pink cells, but I like the whole keratinizing thing. So this is squamous cell in the H&E.
What would you do with this? How would you approach this?
So I agree completely. It looks like a squamous cell carcinoma, and so I don't think this case needs stains. But it's if one were to do stains, it would be a very small panel, right, of P40 and a TTF1 here. But
and if you had to explain, Matt, to a first-year resident, why you didn't do the stains, like why this is squamous, how would you explain?
Yeah, so it's got clear squamous differentiation, and I think we were just describing this dyskeratotic cells, the intercellular bridges, for what that's worth, and then the absence of glandular differentiation. If I did see an area that had more glandular differentiation or potential glandular differentiation, then I would do the stains, and because that's, if there is an adeno component, then you're going to want to do full biomarker testing as well on it, right? And so I have a low threshold for ordering the stains, just because the testing is different for this. Because this case, I would just order PD-L1 for biomarker testing and not do the full NGS panel for all the fusions and driver mutations.
If it's not, if it's.
Yeah, so I completely agree. I do stains when I feel that it's a variant of squamous cell carcinoma, something like not a classic look of squamous cell carcinoma, like all the features, how everybody has described so far, like a pseudoglandular squamous cell carcinoma, something like that, then I would do stains. Otherwise, I rely on histological features and try to sign it out and get a PDL1. And like Matt mentioned, if there's an adeno component, I will save the tissue for molecular testing. Otherwise, unless it's like a variant, more clear cytoplasm, like a clear cell variant of squamous cell, unless it's a variant, I would just go straight away, diagnose it. But There's also, I also was interested to see the rest of the needle core biopsy. There was some pale basophilic areas in the background. So I was curious what Irene has got us in store.
Well, first here, I want to say that I find that for residents difficult when I show this, like these kind of glands that are not glands, are entrapped epithelia, but this can make people think that this is an adenosquamous, and this is totally benign.
Can you show it, Irene, a little bit higher, Mag, and that will be really good for residents to see what that looks like. If, at high Mag, the entrapped epithelium, yeah, like this. Yeah, that's a great point. I also feel that not just residents, I think pathologists also get misled by this.
We say residents.
This is a glandular.
We say residents when we want to say this is a pretty obvious thing for lung pathologists, but for residents, and we say so. But many people can confuse this, even lung pathologists at some setting.
I think it gets tricky too, especially when you do the stains in these cases, right? I think that because you'll see some TTF1 positivity intermix, right?
Very high and very big in the stains, right?
Yeah,
absolutely right.
And then I think that's the other pitfall where you then want to call it adenosquamous when it's picking up the entrapped pneumocytes in the middle of the lesion.
Yes, that's what I was going to say, Matt. When you said you do stains if there's a glandular component. And to my counter to that would be, why would you do it if there's an obvious malignant glandular component? Because if your stain is, because the stain really doesn't help in that situation. Like you're already convinced that there's an adeno malignant component and a malignant squamous component, so you have an adenosquamous carcinoma. In a thing like this, where you have a benign entrapped component, you can actually be misled by doing the stains because you'll be TTF positive and you might think, hey, that confirms my diagnosis. So actually, it's a little tricky if you have a glandular component, whether the stains help in any way or not.
Yeah, I completely see what you're saying. I guess it's more helpful if it's a potential poorly formed glandular component, not just acini throughout, right?
So Raghav, you take me to where you said it was.
I think the basophilic areas right here.
Here?
Yeah, stop right there. Yeah.
Are lymphocytes, aren't it? Or this is a vessel?
Yeah, just the background was a little funny looking because it has got more elastosis in the background.
I think it's from the apical cap.
The stroma, yeah.
Yes, like here, I think we are in the apical cap.
Yes.
And maybe the carcinoma has appeared there.
Exactly. So the stroma here is pale basophilic, little bit of amphiphilic kind of appearance. But if you go to the areas where the nest of squamous cell carcinoma is present, in that the background is slightly more basophilic, maybe a little more myxoid matrix. Yeah, more blue.
Infiltrative.
Yeah, maybe there's a component of stromal desmoplasia coming in, which is making it bluer. I'm not sure why it's a little bit more blue. It is.
Yeah, it's exactly at the infiltrative area. So I agree with Sanjay that it might be the desmoplastic reaction giving that little more color to the fibroelastosis in the background.
Okay. Actually, I had some keratin here, but this got folded, and here we can see keratinized epithelia. We can move to the.
Yeah, and one more thing I'll add, Irene, if you could just bring it to any one of the tumor nests, just focus it on any one of the tumor nests. Just bring it to the center of the field. I would say that for a beginner in lung pathology, it's important to know that unless it looks clearly squamous, which it does in some areas here, it's not a bad idea to do the stains because solid things like this can also be solid adenocarcinoma. So that's really the decision you have to make. Is it clearly squamous on the H&E and you don't need to do stains? Or are you not sure and then do the stains, TTF and P40? Because the differential here is a solid variant of adenocarcinoma. But like we discussed in this case, I think we are all on the same page that that's really not an issue here.
Squamous carcinomas are P40 positive, all of them, or almost all of them. So it's very few immunohistochemistry that you have to do. So be sure to to make this diagnosis quickly.
So I have a question. When do you do musicarmin? Do you do it at all, or do you just take it out? You just do TTF1, P40, basic 2 stains like everybody recommend, or if at all, is there a place for doing musicarmin?
So my take on that is, Raghav, that when there is significant mucin, so enough mucin that you can call something an adenocarcinoma, that mucin is usually visible on H&E clearly. And when there is not significant mucin, so when there is, you're really struggling, is that one little blob, a mucin blob, even if you find that that's musicarmin positive, it usually you're still in doubt whether this is significant or just an entrapped gland or some sort of a bronchial epithelium. So I don't, at least in my bias, I don't find doing musicarmin is really helpful. But I do know people who do musicarmin stain even in the current day and age. So it's I think it's a matter of personal preference whether you do musicarmin or not.
I find it difficult to interpret.
Yeah, that's the most important point, especially on the needle core biopsies. I don't even think about doing musicarmin on resection specimens. Only if my colleague mentions about musicarmin, I'll bring it in. Otherwise, I'm happy to forget about musicarmin.
Agree.
Yeah, remember, I mean, the one thing for first years to remember is that musicarmin is not only positive in tumor cells. It can also be positive in, goblet cells in the bronchial epithelium and, other cells here and there in slight blushes. So just because something is musicarmin positive does not necessarily mean it's adenocarcinoma.
That's a great point.
Great point.
We move to the second case. It's a woman, 60 years old, and she has a mass in upper right lobe. And
can I just say that your scans are absolutely beautiful. These are just so clear and easy to see. Yeah, beautiful.
Thank you. I'll tell to the technicians. They did the work. In this case, the patient has images of dissemination. He has lesions everywhere. Because you said you would do PDL1 in the other one, but if it was going to be resected also, you are doing biomarkers in all the cases?
Yeah, and that's just how it's funded in Ontario. We reflex biomarker testing on every newly diagnosed lung cancer, regardless of stage or anything.
New diagnosis, not that you do in every sample, because some people think when they say reflex, they say no, there is the diagnosis adenocarcinoma, and we do NGS. Let's say this is doing NGS in multiple samples. Sometimes.
Oh no. That would be a large waste of money, right? They would. The only time we would repeat is if it fails, right? So sometimes it fails on our small biopsies if there's not enough tissue, and then we'll repeat it on a resection if one is done.
No, I say it because people think that when they say reflex, that you are not going to, that it is going to be easier, that you don't have to check the history if it's done in it, but you have to check some things, that if it's done, if it's a new diagnosis, you have to do some work also. It's not automatic.
Yeah. Correct. No, I don't think that reflex, at least we don't interpret the meaning of reflex to mean that you don't think at all, I think reflex means that the pathologist does the ordering instead of the clinician.
But this is a made up definition, because reflex means automatic or unintended.
Yeah.
Right.
Yeah, it's a
reflex.
Yeah, it's a pathologist reflexes, not others.
So here we have this biopsy where we can see these atypical cells that, in my opinion, here are in normal parenchyma maybe, but here we can see some desmoplasia, or maybe we see desmoplasia everywhere, and this look like malignant glands, gland forming, in my opinion.
Agree.
Also,
yes, agree. Clearly malignant adenocarcinoma. So
in our case, I don't do any immunohistochemistry in this case. If the history is that clear that the patient has a lung mass and doesn't have anything anywhere, I'll go for NGS and PDL1 in this case.
But you said this is disseminated, right, Irene, or did I understand that wrong?
Disseminated.
Did you say that clinically?
That's why I'm not doing.
So what does that mean? Multiple lung nodules, or how do we know that this is?
No, that has lymph nodes and maybe a lesion in the liver or in the whatever.
Oh, I see. But clinically lung cancer.
Clinically, a big mass in the lung and no history of anything else. Some lymph.
Of anything, yes. Yeah, agree. At least my also approach would be not to stain this and to save it for molecular.
This is a very quick diagnosis. You have the biopsy was taken yesterday, and you have the diagnosis today, very early, because we label this important, or we label this kind of biopsy, so we know very early that this patient has adenocarcinoma, and we can start everything.
Yes. So Irene, I think we should have a little discussion on why we think this is malignant for the first year resident, why this is malignant, and why we do or do not stain with TTF1. I mean, that's a very long discussion, but at least the malignant discussion we should have now. Raghav, can you explain to the PTY1s why this is malignant?
Yeah, so I can try. So basically we have atypical glands, irregular growth pattern. Most of them seem to be acinar because they've got this tubular or elongated glands with surrounding stroma. But if you see the overall growth pattern, they've got this irregular appearance and infiltrative kind of appearance, infiltrating into the surrounding stroma. And if you zoom into the individual cells in those glands, they have significant cytologic atypia in terms of different sizes and shapes of the nuclei, and many of them has got irregular nuclear membrane and prominent nucleoli. And the cytoplasm seems to be on the moderate to less amounts compared to the nuclei. And also, if we look for it, we might find some mitosis as well. Because of the features.
Or no, it depends on your approach to mitosis.
depends on the 1000 mitosis project. Yeah. So because of the following reasons, I do think would be the features on the H&E stain to call it as adenocarcinoma. Again, the biggest one is the glandular pattern, what it's exhibiting with cytologic atypia, why we call this adenocarcinoma.
Yeah, Matt, what do you think? So what are your criteria for calling this malignant?
Sorry.
So I agree completely, and
I wanted to show you again the non-malignant glands we saw before.
Yes, for comparison. Yes.
So it's a very round, not infiltrative appearance. They're largely maintaining their polarity and their spacing with one another. I find the spacing is very helpful. They're very they're nice and orderly fashioned. It's like, you know, when you go, like during COVID, we had all those spots on the floor that you had to stand 6 meters apart. It's like the cells are all behaving themselves and standing 6 meters apart from one another, right? And you know, and the tumors just don't respect their neighbors and just are all jumbled up. And so I find the spacing helpful as well.
And I noticed that in your description, Raghav and Matt, that nowhere did you say that this is TTF1 positive, that's why it's an adenocarcinoma. So the whole distinction of malignant versus benign is all H&E, correct? Would you agree with that?
Absolutely.
Which is really the most difficult thing that people struggle with, is that when it's so obvious, like in this case, it's pretty easy. But when it's less obvious, people struggle a lot, and they try to get assistance from a biomarker, which really does not help you in this situation. I don't know if you guys agree with that statement or not.
I agree completely. The other thing I find people sometimes struggle with is on biopsy, struggling to say if it's lipidic or invasive. I don't know what people's thoughts are on whether you even comment on that in a biopsy.
Yeah, I know we are slightly different in that situation, but I don't because I feel that firstly, it's very difficult to tell, you know, in some cases. So in some cases, it's easy to tell what the growth pattern is. In some cases, it's difficult. And second, I think that people greatly overestimate lipidic growth pattern on biopsies. And third, whatever growth pattern you give on a biopsy, on dissection, something else can always appear. So I feel it's very misleading to say that something predominant on a core needle biopsy when on resection everything can change depending on another area. But Raghav and Irene, I would like to hear how you approach that. Do you mention growth patterns and why?
I used to, because it's written in the blue book that we should list the patterns, but I think it's useless in the case of biopsies, because you won't do anything different because of the patterns. So it's a lot of work for nothing.
Yeah, I agree. We don't mention the growth patterns. Only scenario would be when we have very few cells, tumor cells. Otherwise, mostly it's alveolated lung parenchyma or fibroelastosis, but very limited tumor cells. And if they are demonstrating, if we think that it's a lipidic growth pattern, then we try to mention that this might represent lipidic growth pattern, and this may be any of this adenocarcinoma in situ, or minimally invasive or invasive with lipidic predominance, and definitive classification on a resection specimen. That's the only scenario we'll try to hedge, but otherwise we shy away from mentioning any growth patterns, because at the end of the day, those things may become important on resection based on the new IASLC grading, but not on the needle core biopsy.
If I'm going to do NGS, I have to say the percentage of tumor that I have here. How much tumor would you tell?
It's a challenge.
We all know, Irene, this is not a science. It's just a guess, right? So yeah, I try to ballpark it. I'm like, is it half and half? In this case, I feel so. I'm trying to think: is it half tumor cells and half non-tumor cells, or is tumor more than non-tumor? I start with that, and then I progressively refine my guess. So here, I would say, yeah, it probably is around half and half. If you consider all the non-stromal, so maybe 50% would be my guess here. It's completely non-scientific, probably completely inaccurate.
The point is we have to think only in the nuclei, not in all the tissue.
Yeah.
No, so we
Correct.
from the nuclei of these fibroblasts and vessels and lymphocyte, how much is? I maybe would say 40, 35, something. I'm less generous than Sanjay.
Yeah, and
but
what do you think, Raghav?
Yeah, I'm a little more conservative. Like Irene was saying, I was exactly in the same ballpark, like 40%, 35, because I see a lot of lymphocytes. More nuclear material would interrupt, means it comes in way with the tumor purity when you're doing the molecular testing. And also, I would find very difficult to mark this slide exactly where they want to capture the glands when they're
you have to
taking...
put the whole thing in this case.
Exactly. So when we're including the whole thing, you're including so much of non-neoplastic nuclei, especially the lymphocytes and the stromal cells. So I'm more conservative on this. The tumor purity, I think I would be like 30 to 40, maybe I think 35, 40. Again, it's subjective, like Sanjay was mentioning.
Totally.
Yeah, and I agree with you guys. I think I would macro dissect this case. So we circle and macro dissect most of our cases with our protocol. So I would probably take some. I drew it all over. But
yeah. This part is the more tumor.
Yeah, and
Yeah.
I think that as everyone said, the lymphocytes, they look smaller, but they have the same DNA content. So we tend to overestimate those, and in general, often it's we overestimate the amount of tumor cellular there.
I would macrodissect this part, so I won't macrodissect. I mean, because the only part I want to remove is this one, but I imagine there are different approaches for that.
Yeah. Cool.
Can we move to the next one?
Yeah.
Yes. This is okay.
Ooh,
I'm sorry.
They're already immunostaining done, so this must be complicated.
Or not? Maybe it's very easy. This is a 55-year-old man with multiple pulmonary lesions and multiple lymph nodes positive. And we have it's the lung. It's a biopsy of the lung.
It's very blue.
It's blue.
Wow.
With necrosis.
Yes. So for me, at least, Irene, can I give you my impression, or do you
ahead.
want to?
Go ahead.
So, it's clearly malignant high-grade carcinoma, right? There's a little azoparty effect on the right-hand side. So for me, the differential here is this a small cell carcinoma or a basaloid squamous cell carcinoma, or poorly differentiated squamous cell carcinoma? And that's how I, would approach this. Because this could easily be also a met from a high-grade squamous cell from the tonsil or something like that. And it could easily also be small cell carcinoma. So I would do the neuroendocrine markers, keratin, P40, TTF. That would generally be my approach.
What is your panel, Sanjay? Which is your panel, your immunohistochemistry panel?
Yeah, so in a case like this, it would be keratin, A1, A3, TTF, P40, synaptophysin, chromogranin, INSM1. That's what I do as a standard when I'm suspecting small cell in the differential.
I do 7 cytokeratin. If it doesn't work, I go for, I don't know why. Sometimes cocktail, sometimes 7. In this case, I did 7. This is, I guess, the normal alveoli, and these are the cells. It's not membranous, but it's not neither dot or not perfect dot. Here we see some dots, but it's in the middle of membranous.
I feel that dot-like thing is too much overemphasized in the literature, and people. I don't care whether it's dot-like or not. Just that it should show that the cytoplasm is scant, at least for when looking at small cell. That the immunohistochemistry frequently supports your morphologic impression that there's very scant cytoplasm. So the staining is very minimal and delicate on a keratin stain. It's not always dot-like, and I feel that idea that it has to be dot-like is wrong. What do you think, Matt? What do you think about that?
I agree. I think it's just exactly like you said. It just highlights the scant cytoplasm, and it typically doesn't look like the normal epithelium there, where you see it kind of surrounding the whole thing, but it doesn't have to be dot-like.
So Irene, if you can bring in the normal epithelium just to contrast, then for the students it'll be great to see what an amount of cytoplasm in normal epithelium on a keratin stain, like this, versus the amount of epithelium in a presumably small cell carcinoma on the left hand side. But we don't know that for sure, right? We don't know.
I'm doing now. I only do 2 neuroendocrine markers: chromogranin, that it's here. That this is very, very positive. This is diffusely positive, but can also be focal, just like synaptophysin. But be cautious with if it's focal, because you have to have also the cytokeratin before calling something a small cell only by a focal synaptophysin, because many things stain focally synaptophysin. And I don't have the INSM, but I did. Now I'm doing chromogranin and insulin INSM. And TTF1.
You can see the azoparty effect even on the immunostain, because there are little blood vessels with that deposition of the thing.
Yes, you saw it in the first one. Even here.
That. So if you go to HiMac here, Irene, there are some blood vessels that are floating off to the side, with that little. I mean, you can't see it as nicely as on the H&E, but you can see them here also.
Okay.
I think this is an important teaching point too with the TTF1 in small cell, in that it's not necessarily means this is lung. Any small cell from any organ can express TTF1. It's just an aberrant expression of it. And so I sometimes see trainees, right, consistent with lung origin when the TTF1 is positive, and I don't get that.
But in case of carcinoids?
In carcinoids, yes.
There it is Babel. Yeah, so the rule is if you have a low-grade neuroendocrine neoplasm or epithelial neuroendocrine neoplasm, then TTF1 is a reliable indicator of lung origin, like in carcinoid tumors. But if you have a high-grade neuroendocrine carcinoma, like a small cell, then TTF is not reliable for lung origin, because other things also do it. Prostate, esophagus, bladder, wherever can be positive for TTF1. I've even seen tonsillar small cell being positive for TTF1.
And other lineage factors can also be expressed, like CDX2 and SAPB2. Like I think it's often called like this lineage factor infidelity, where they just start expressing different things, and so it doesn't mean it's not long, even if it's making SAPB2 or something like that.
Great point. Yeah, SAPB2 especially is notoriously overexpressed in small cell carcinoma. That's a great point.
Yeah, I have a couple of questions. So in this case, straightforward, you get the panel, it's just doing the way you're expecting, it's reading the textbook, and it's worked out. What if the keratin is negative, the pan keratin or CK7 or keratin 7, what you've ordered is negative, and the neuroendocrine markers are positive, TTF1 is positive, and again, Matt made a great point that TTF1 positivity doesn't say the origin. So now we have a keratin negative, that is the first keratin what you have used, and then TTF1 positive, neuroendocrine markers positive. Now, would you still call it small cell, or do you do more keratins, or what is your approach? And when do you bring in Ki67?
So Raghav, in my experience, this is not a common situation. It's not common to have keratin negative, and remember I'm using a keratin A1A3. It's very unlikely to be keratin A1A3 negative, but positive for the neuroendocrine markers. It's more likely to be actually the other way around, which is negative for the neuroendocrine markers, but positive for keratin. But in the situation you're describing, let's say hypothetically that happens, then I rely heavily on the clinical setting. So if it's a smoker with a higher mediastinal mass, morphology is perfect for small cell, I might call it small cell even based on that. If there's any doubt, if it's a younger person, the morphology is off, then I probably would not, and then I might repeat a keratin, do something else, investigate further. But I feel that this is not a common situation to have keratin negative but neuroendocrine and TTF positive.
What is Matt and Irene think?
I'll try with another, as I did CK7, I'll try with CAM 5.2. That is, at least focally, I find in most cases, but if it's not with all this panel, the TTF1, the neuroendocrines, I wouldn't believe in one marker. I mean, I would call it a small cell without the cytokeratin if this CAM 5.2 is negative also.
Yeah, I use a pan keratin right off the bat, so it includes A1, A3, and a CAM. So with that, I get 2 keratins off the bat, and I have to say too that's quite uncommon for that to be negative. And then I would probably make sure that it was nothing else as well. It would be uncommon for a lymphoma or something like that to also stain for neuroendocrine markers, but I would just take a step back for the with the immunoprofile and make sure it's not one of the differentials of a small round blue cell tumor, like a lymphoma or a rhabdomyosarcoma or a melanoma or something like that. So depending on what else it was, I'd probably expand my immunopanel a little bit as well.
Yeah, I do the same thing. I combine a CAM 5.2 sometimes with the pan keratin because ours doesn't have the same thing as CAM 5.2. Just to make sure that it covers all the keratins, and then if rarely it's negative with that. And I follow the same rules as Sanjay and Matt were mentioning.
We all do immunohistochemistry, we agree. Because it's supposed to be an H&E diagnosis.
I'm not that brave.
I will confess. So sometimes, you're on a busy day. This is the last case of the day, or, on a weekend and clinicians are looking for a quick diagnosis. Sometimes I will diagnose it on H&E and do the stains later. I've actually never had, and really I'm using never in the true sense. I've never had a case where I called it small cell carcinoma on H&E and it turned out something else on the immunohistochemistry. So it's always been correct. So I think there are exceptions. You can be wrong on H&E, but it's very rare. It's very rare to be incorrect on your H&E diagnosis. So I understand people, especially old-fashioned, people who trained in the pre-immunohistochemistry era and who still feel that it can be made on H&E. I understand where they're coming from because it's very accurate. But still, I think people in our generation mostly do stain with immunohistochemistry.
There are new diagnoses, just like neoplasm, and that can look like a small cell or so.
When do you guys do nut staining? Like when do you actually like what panel does it have to be staining for you to add a nut stain to your panel?
Sorry?
That's a great question, Matt. Yeah, go ahead, Irene. You go first.
No, I didn't understood the question. Sorry.
No, I was just asking when do you do the stain for nuts? Like in what scenario, what profile? Like when do you add that to your workup?
No, and I have no idea. When they ask, and the few cases I have had is that they have this abrupt keratinizing, that you see like a small cell and abrupt keratinizing. They are the two cases where I have picked. And maybe I should do all the squamous or all that look basaloid, I don't know, but I'm not doing it. And in the times I have done it in squamous, it has turned to be negative. So.
Yeah, I agree with Irene actually. So, when it's morphologically clearly nut, when it's keratinized, has abrupt keratinization and so forth, I think it is absolutely mandatory to do the stain. So for example, you have a young person, a big mediastinal mass, abrupt keratinization, everything is great, nut is a great idea. But the idea that we should be doing nut in every poorly differentiated neoplasm, actually, I have been doing it on poorly differentiated neoplasms that don't fit. The yield is very, very low, I find. It's very, very rare for nut to be positive in those cases. So it's not very productive, I would say, to do it in those situations. But, one good setting to do it is if your stains don't make sense, or if it's a relatively young person, if there's a mediastinal mass, if the keratin is negative, those odd situations, I think nut is a good thing to do. Or if you have a discrepancy between P63 and P40, that's another kind of clue. But again, yield is very low to actually find a nut positive case.
Yeah, agree with that. Yeah, for me, yeah, when something is odd, I look at the age of the patient. I know the nut can happen in younger to older, like almost 70, 75-year-old. So there's a wide age distribution of nut carcinoma. But whenever I see a younger man, non-smoker, again, I don't know the literature if nut midline can happen in a smoker. But if a non-smoker, younger, and then like the stains doesn't make sense or doesn't fit together, like everything is so odd. So when I think it's an odd kind of scenario, that's when I do nut. Otherwise, again, we don't have the stain in now, so we have to send it out. So I have to carefully think about doing it.
Yeah. Is this the key 67 here?
Yes, I showed the key 67 that it's crazy positive.
What a shock. Right? I mean, I feel about the Ki67 in a overtly high-grade carcinoma. What is the point? It's like, it tells you what you already know from the H&E. Would you agree, Irene?
Yes, in this case, it's because it's part of the panel. It helps when it's crushed. It's the big use of Ki67 is when it's crushed and you can see the morphology well. It helps.
Yeah, I do it only in selective scenarios, like when you have a small sample and you have the cells at the edge of the biopsy and they're all crushed. That's when I use Ki67 when I really want to differentiate from a carcinoid tumor. Otherwise, when you have acres and acres of land where you can see it's all high grade, I shy away or save money not doing Ki67.
It's a problem to do it because it has happened to me. This neoplasm with a low Ki67. So what? I said small cell anyway. So for what? Because sometimes it does, very, very few times, but sometimes it doesn't work or something happens and you find that there is no Ki67 in this case. So what do? You call it a small cell again. So for what? What's the point in that?
I think people who use the Ki67 tend to gloss over the technical problems with the Ki67 or exceptions, because yes, it is true that small cells will be positive, blazingly positive in most cases, and carcinoids will not. But things in between will cause problems where there were no problems on the H&E. So you might actually create problems where there were none. But I would like to hear the other side of this. So Matt, why do you do the Ki-67, and do you ever encounter problems with Ki-67 interpretation?
Yeah, so I don't do it in all cases, but there's often a clinical request for it. I think some of the clinicians like to know what it is. I think it gives them a sense of how fast it's growing, or I'm not sure how they actually change it, right? Because all small cell are really going to get treated the same. But that's the one aspect of it, and I agree that the best use is in the small crush biopsies where you don't want to overcall a carcinoid, right? Because that can happen, right? If you can't.
Yeah.
I think you have to be really careful in neuroendocrine things if you don't see clear mitotic activity or necrosis. If you don't see lots of that in a small biopsy, I think a Ki-67 is mandatory before calling anything high grade, because it's definitely a pitfall that you think you wouldn't call a carcinoid small cell, but in limited tissue or in crushed, it is possible.
This is a woman that has hemoptysis and hilar nodule, central nodule.
What did you say, Irene?
Hilar, no, central. I said related to hili or ilium. I don't know the word, so better central.
Oh, the hilum? Yeah.
Hilum. Hilar nodule, without any lymph node or images suggestive of metastasis. So we have this transbronchial biopsy where you can see the cartilage. You see also this. So any of you, if you want to tell what you see, I'll go around.
Yeah. Okay, can I go first?
Go for it.
Sorry, I'm always accused, since my early residency days, of jumping to conclusions too quickly, but that's just my style. Anyway, the idea here is that to me, this is a clearly high-grade malignant neoplasm.
Yeah.
And there is a hint, to me at least, of slightly, the cells are very poorly differentiated, or almost sarcomatoid looking. So my first thought here would be, could this be a sarcomatoid carcinoma? That's my first impression. I think this is clearly malignant. It could also be a poorly differentiated squamous cell carcinoma. I think it's unlikely that this would be an adeno, but my first thought would be to get a keratin, TTF, and a P40, and I think that will solve the issue. It probably is a squamous cell carcinoma, and my thought is that it might be possibly turning sarcomatoid in some areas. So that would be my panel. 3 stains.
Anyone has another idea? They have only 2 stains.
I think there might be some dyskeratotic cells, but I don't think there's enough for me to not just call it on H&E alone. I would do the stains.
Okay, Raga?
Same. I will do the stains. There's some hint of squamous differentiation there. Otherwise, predominantly spindle cell or sarcomatoid features. So looks like we are dealing with a poorly differentiated malignancy. So I would do stains on this as well.
This is TTF1. The cells are.
Wow.
The malignant cells are positive.
Yeah. Beautiful.
And I work with the 8G7, so it's highly specific. This is normal. This is the epithelium, and this is the TTF1. And the P40, it's highlighting basal cells.
Wow.
And the neoplasm is negative. So this is
amazing.
A good reason to do immunohistochemistry, despite we think that there are these keratotic cells, and so I think it could be a pleomorphic one, but I didn't say that in this biopsy. I have a high threshold for pleomorphic in the small biopsies, so I have to see something, because sometimes I said could be pleomorphic, and in the the resection it comes that there is not this pleomorphic look anymore, and maybe it's part of I don't know.
Agreed. No, I agree with all of that. I mean, first of all, I agree that this is a great case to show how something can look squamous but actually turns out solid adenocarcinoma. I think all of us were kind of leaning in that direction. So that's one great point. The second great point is very easy to overcall sarcomatoid because it's very subjective, in the eye of the beholder when something looks sarcomatoid. So I feel that there is a lot of variability in what looks sarcomatoid to one person and doesn't to the other. It might be that this is just high grade and that's why it looks funny. It's just a high grade poorly differentiated.
Or a bit cryzed also, or this. I guess it's a cryobiopsy because we do well, but we don't see this artifact in cryobiopsies. I'm talking so, but maybe this is artifactual. This elongated look.
Yeah.
That we see here is not real.
It's probably useful.
Some of it might be dermoplastic stroma and with some spindle cells. I don't know.
It's probably useful for trainees to mention what we would call it if it was just keratin positive but negative for TTF1 and P40, which can kind of be common in a poorly differentiated tumor like this.
Yeah. So at least for me, this would be in that scenario. So malignant tumor that looks like carcinoma, keratin positive but negative for TTF-P40, I'd just say poorly differentiated non-small cell carcinoma. And then in the comment, I say the current WHO term for this is NSCLC-NOS, so not otherwise specified.
Yeah, the other point I wanted to make is agree with that point. When I have sarcomatoid features or I'm thinking sarcomatoid, I always add a pan-keratin to see if those cells are staining with keratin versus desmoplastic spindle cells or fibroblasts, which would not be keratin positive. That way, I'm trying to match if the same cells are positive for keratin to make that comment or at least raise the concern for a sarcomatoid differentiation in my comment, especially on the needle core biopsy. But otherwise, when the TTF-P40 both are negative, I do exactly the same as Sanjay said.
I do the same.
And then send this for molecular testing because a lot of these can have actually like MET skipping mutations, right? Even when they're sarcomatoid.
And it's so important. If TTF1 wasn't positive, it's so important to have the keratin because some things we should we shouldn't do a very large panel of immunohistochemistry. We should think in NGS, but a keratin is very important because there are some things that look like a carcinoma and are not carcinomas.
Great.
Yeah, agreed. Great case.
Great case.
One more?
Yeah.
Sure, let's do it.
This is a 60 years old man with a mass in the left upper lobe. Again, if some of you want to make a mistake, go ahead. I'm saying it. I'm just saying it. No, please be brave. Sanjay was.
Okay, let me do. Okay, so for solitary lung mass, and that's what you said, right? Irene, solitary lung mass and an elderly patient, correct?
Mm-hmm.
Yeah, so,
if
first
you
of all,
think 60 years old is elderly, this is
elderly, yes. Soon I'm going to be 60 years old in 10 years, and I'll be elderly. No, I mean, elderly meaning in the appropriate age group for a lung cancer.
In the appropriate age group for lung cancer. Right? Very well said.
Right. So I think this is clearly malignant and is at least morphologically looks very epithelioid and certainly good for carcinoma. Also, if you come down that path of small cell or non-small cell, this is clearly non-small cell. So I would be going down that path unless there's some trick in the history. So unless there's a previous history of something else or there's a malignancy in the past, I would be going down the path of a non-small cell carcinoma, and then I would also do the same thing as in the previous case. I would do a keratin TTF-P40.
Do you do the keratin always?
If there's some difference in the clinical history.
Sorry, do you do the keratin always, or because it looks a bit?
I think it's reasonable to skip it here because it's so epithelioid looking. But here, one thing that's in the back of my mind is and very weakly, not really strong, is a SMARCA4 deficient tumor. The reason I say weakly is because those are, in my experience, more discohesive. But there's a little bit of a rhabdoid look to some of these cells, so keratin would be helpful in that situation.
Yes.
But I don't think that it has classic SMARCA4 morphology.
I agree. But I went for the non-small cell pathway. So this is TTF1. It's negative, but it has some things here that you could think that are entrapped, or you could think that are part. If you think in what Matt said before, that cells are separate here, are helping to say it's reactive. This is clearly reactive. I would say also hobnailed also helps for saying it's entrapped epithelia. So TTF1 is negative.
Yeah,
Natasha, can I make one more point? So the cells you're showing as reactive, if you compare the nuclear size of that with the tumor, it's much smaller, much smaller.
Much smaller.
So that also helps. I mean, I think that's really the most helpful feature for me, is that those cells are much smaller than the malignant cells. And
the hobnail you're mentioning, it resembles like a Napoleon's hat. Natasha recommended that comment in her paper about the reactive pneumocytes.
Oh, this looks just like a little hat. This one.
Yeah, it does.
Very, very cute. P40 was my first panel. P40, clearly negative. Clearly negative. So second round, keratin. It's negative. A smaller rat.
Now SMARCA4 becomes a big issue. Now SMARCA4 is
this is not a gland. This is not a gland. It's necrosis. Maybe
it's
you could think
comedonecrosis.
Comedonecrosis. No. Well, I did a lot of things. Also, as Mark, I'll save you the amount of things I did. Here's napsin 1 to ask you if TTF1 is negative. Do you do napsin A?
No.
No?
I don't. No.
I do. Sometimes it has helped me. Sometimes it has appeared positive, but in this case, it's only bothering or only confusing, because there are some cells positives here and there, but I think are no sensors.
They're probably
yeah, we have a dual stain, napsin and TTF1 combination, so we do that.
I did many immunohistochemistries, or too many for lung cancer. And I said, why not? Well, when you have something, cytokeratin negative, why not one melanoma? And this is the
melanoma.
10.
Great idea. Great idea.
Like a slap in your face. Melanoma.
Yeah. Wow.
Incredible.
Great.
And melanoma positive, and it really looked like a carcinoma. Also, to the derm pathologist that I showed to her, she couldn't find any. She couldn't find any pigment, and she said it really looked like a carcinoma, but it was a melanoma.
Yes.
No history of melanoma.
Well, okay. Now that I'm wrong, let me just put in one more plug for differential. I think it's a good idea, although I didn't do it, that whenever you're thinking SMARCA4, also think of melanoma.
Great.
Because it's rhabdoid, just like.
Yeah.
The two melanomas I had, the two melanomas I diagnosed in lung, they had no previous history of melanoma. So it's a thing to have in our minds.
Okay.
Yeah, a couple of points I want to make. So the melanoma looks like your best guess, whatever your specialty you're practicing. For a breast pathologist, it looks like your high-grade ductal carcinoma. For a lung pathologist, it looks like non-small cell carcinoma. For a GI pathologist, it looks like an high-grade adenocarcinoma. So doesn't matter which your practice you're doing subspecialty, it looks like your most familiar tumor to you in your specialty. That's the best thing about melanoma. The other day, Sanjay showed something on the Twitter where the melanoma was doing this lipidic growth pattern. So it makes you think that it is one of your familiar friends. So I always remember to follow the keratin pathway whenever there's in high grade, which I think I need to exclude other entities. It always starts with a keratin. So once keratin negative, then I fall into my path of adding 4-pack, the S100, in my case, or SOX10, then Desmin, SMA, and then keratin, which is the 4th pack of, because I don't have a 6-pack, so I start with 4 packs.
That's great.
Have you heard last
Yeah.
Shakira's song? The singer, Shakira?
Yes.
Shakira.
Oh yeah, Shakira.
Says, I cheer you because you are a good actor. So the good
Oh, yeah.
acting, the melanoma is the
Yes.
good acting. So
Oh,
Yes,
yeah. So
you
it's
can
the
put it
Shakira
here
of
later.
pathology. Melanoma is the Shakira of pathology.
The Shakira's boyfriend or Shakira's husband in this case. I think.
Great case.
Great case. Thank you for sharing.
Yeah.
Well, thanks everyone. I think that's was a really great episode of Fresh Air. Hopefully everyone learned something, and stay tuned for some more exciting episodes for season 2.
Yeah. Thank you. Thank you, everyone. Thank you. Thank you.